Welcome to our video on complications in the newborn period, respiratory pathologies. Let's get started. Here's our overview slide. Let's begin by discussing respiratory distress syndrome. Neonatal respiratory distress syndrome is respiratory distress secondary to a surfactant deficiency. A deficiency in surfactant results in high alveolar surface tension. This high alveolar surface tension leads to low lung compliance and low lung volumes with alveolar collapse, causing respiratory distress. This syndrome is most common in extremely premature infants who have a surfactant deficiency due to immature lung development. The severity of their surfactant deficiency and respiratory distress is related to gestational age. The younger the infant is at birth, the more severe their respiratory distress will be. Other risk factors besides prematurity include maternal diabetes and cesarean delivery. The clinical presentation will be a premature infant with signs of respiratory distress such as grunting or cyanosis. The diagnosis is based on their clinical picture and can be confirmed with a chest x-ray. Chest x-ray in infants with respiratory distress syndrome will show a reticulogranular ground glass pattern with air bronchograms. The lung volumes will also be low, which will be an important factor in order to contrast respiratory distress to other respiratory pathologies in the newborn. Here is a chest x-ray of an infant with respiratory distress syndrome. In a normal chest x-ray, the lungs would appear dark. Here, we can see that the lungs have a lighter color and decreased lung volumes, which is characteristic of respiratory distress syndrome. In addition, we can see air bronchograms in the right lung, for example, right here. These are the darker outlines of the bronchi that can be seen on the chest x-ray. In order to decrease the risk of developing RDS, any mother that is at risk for preterm delivery should receive antenatal steroids. Once an infant is born, they can receive artificial surfactant in order to decrease symptoms. However, surfactant can also be administered when an infant becomes symptomatic as a rescue therapy. Infants with RDS may require ventilatory support, either with CPAP or with mechanical ventilation if they're in respiratory failure. If they are receiving ventilation, they should be monitored closely for signs of a pneumothorax, such as tachycardia, decreased breath sounds, and worsening respiratory distress. There are several long-term complications. Two important ones are retinopathy of prematurity, as well as bronchopulmonary dysplasia. Retinopathy of prematurity occurs secondary to exposure to elevated levels of oxygen. This increased oxygen can lead to pathological neovascularization. This neovascularization can cause severe visual impairment that continues into childhood. Bronchopulmonary dysplasia is a chronic lung disease that occurs secondary to prolonged mechanical ventilation and oxygen exposure. This typically presents as a persistence of symptoms that are similar to respiratory distress syndrome. All right, now let's move on to discuss transient tachypnea of the newborn. This is a benign parenchymal lung disorder secondary to delayed clearance and resorption of fetal alveolar fluid. This neonatal respiratory pathology is more common in late preterm or term infants. The risk factors include cesarean delivery and maternal diabetes. The clinical presentation is that of a neonate in respiratory distress. They may be grunting, have increased work of breathing, or have hypoxia. It's also a clinical diagnosis. Chest x-ray will reveal fluid in the interlobar fissures. In contrast to RDS, the lung volume on chest x-ray is increased in transient tachypnea of the newborn. Pleural effusions may also be present. The management is supportive. Like its name suggests, this is a transient condition that will resolve on its own. However, some neonates may require extra respiratory support in the form of oxygen therapy and CPAP until they can clear the fetal alveolar lung fluid on their own. All right, the last neonatal respiratory pathology we'll discuss is meconium aspiration syndrome. This syndrome occurs when a neonate aspirates meconium that they have passed in utero. Risk factors for this condition are the risk factors that lead to the passage of meconium. They include post-term infants, non-reassuring fetal heart rate tracings, placental insufficiency, oligohydramnios, and maternal hypertension, diabetes, and infection. Neonates with this condition will have a similar presentation to neonates with other respiratory pathologies at birth. This includes signs of respiratory distress immediately after birth, such as tachypnea, increased work of breathing, and hypoxia. However, there are two characteristics that are more unique to meconium aspiration syndrome. First, the amniotic fluid will be stained by meconium. Second, infants who have aspirated meconium will have rales or rhonchi and auscultation of the lungs. The diagnosis of meconium aspiration syndrome is clinical and based on a chest x-ray. A chest x-ray of meconium aspiration syndrome will reveal increased lung volumes, asymmetric patchy opacities, and potentially pleural effusions. The management is supportive care with oxygen and ventilation if needed. some infants may require inhaled nitric oxide. This vasodilator can help improve oxygenation in infants with persistent pulmonary hypertension of the newborn secondary to meconium aspiration syndrome. In severe cases of meconium aspiration, surfactant may also be administered to the infant. Meconium aspiration syndrome can also lead to a pneumothorax. This is due to the fact that the meconium can have what is known as a ball valve effect in the lungs. As the infant inspires, air can move around the partial obstruction of the meconium as the airway diameter is larger during inhalation. However, as the diameter is more narrow during exhalation, the meconium plug occludes the airway and the air gets trapped distally. This can lead to overdistension of the lungs and potentially a pneumothorax. Here's a chest x-ray of an infant with meconium aspiration syndrome. Throughout both lungs, you can see the patchy asymmetric opacities that are characteristic of meconium aspiration syndrome. While they're not present on this x-ray, remember that meconium aspiration syndrome can also lead to pleural effusions. Finally, here's a table that helps summarize the information we've covered in this lecture. All right, let's wrap up with a question. A baby boy is evaluated for increased respiratory rate. He was born to a 29-year-old mother 5 hours ago via cesarean delivery. APGAR scores were 9 and 9 at 1 and 5 minutes respectively. His vital signs include a temperature of 37 degrees Celsius, a blood pressure of 70/50 millimeters of mercury, a heart rate of 150 beats per minute, and a respiratory rate of 70 breaths per minute. Chest x-ray reveals perihilar linear streaks consistent with fluid in the interlobar fissures. How does this patient's condition differ from respiratory distress syndrome and meconium aspiration syndrome? All right, this patient is presenting with an increased respiratory rate. His chest x-ray reveals perihilar linear streaks consistent with fluid in the interlobar fissures. This description is consistent with a diagnosis of transient tachypnea of the newborn. Diagnosis of this condition is further supported by the fact that this patient was born via cesarean delivery. Neonates born via cesarean delivery are unable to completely clear their alveolar fluid. Retention of this alveolar fluid is exactly what causes tachypnea in patients with this condition. Now, the question asks us to compare transient tachypnea of the newborn with neonatal respiratory distress syndrome and meconium aspiration syndrome. First, transient tachypnea of the newborn is caused by inadequate resorption of alveolar fluid, while neonatal respiratory distress syndrome is caused by insufficient surfactant production, and meconium aspiration syndrome is caused by meconium-induced chemical irritation of the lungs. Additionally, transient tachypnea of the newborn is characterized by perihilar linear streaks on a chest x-ray, while neonatal respiratory distress syndrome is accompanied by ground glass opacifications of both lungs, and meconium aspiration syndrome is accompanied by patchy pulmonary infiltrates with possible pleural effusions. All of these three conditions may require oxygen therapy depending on the severity. And that concludes this section.